The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to today's Safe and Calm webinar for December 23rd, 2020. You'll notice that I am not Deanna Mitchell. This is Dalton Hervel speaking with Leading Age Michigan. Deanna is out today for the holidays. And so we do ask, if you do have any questions, please submit them like you normally would. Just know that I may need a little more time to look up the answer because Deanna has a wealth of knowledge and experience that I currently don't have. Today, we're very excited to have a couple of guest speakers. As you can see with the agenda coming up on the slide, we'll be going over the Safe and Calm holiday webinar schedule. I will be covering on some of the advocacy topics as relating to lame duck. Then we'll have a presentation by Elisa Lintmuth about vaccination and mandating of vaccines. She's with DICOMA. And then lastly, we'll be joined by Dr. Dana Prince, who is the Executive Director at St. Anne's, who will be covering the CRC process, kind of a general overview and lessons she's learned being a CRC. So the holiday webinar schedule. Today is going to be our last regularly scheduled webinar until after the new year. As you can see by this slide here, the 25th is a holiday and we'll not be holding a webinar. The 30th, we do have tentatively scheduled, but we will cancel it if we don't feel there's been any relevant information, especially around vaccines. And then on the 1st, we will also be having another holiday. So we will not be holding a webinar on the 1st. So moving into lame duck, the 2020 legislature wrapped up on Monday after a special session was held because they needed some extra time. They passed a number of bills, a large number of bills. So the governor has a lot on her desk to consider. Most importantly, they did pass a supplemental bill, a supplemental budget bill, that is. You may have also heard that there's a national COVID-19 relief package that has been sent to the president's desk for signature. It is important to note that this package does not have state budget relief in it. If you remember last week, I mentioned that they took kind of the conversation around state funding and legal immunity on the national level out of this COVID-19 relief package. It does have a lot of good stuff in it, but it does not have those kind of things. So when you're thinking of what challenges the state still faces for next year in terms of its budget, those are still very real because there has been no federal relief passed, and our state has kind of been planning on some federal relief coming through. It is important to note that for the following slides, the bills that I'm about to talk about are not law yet. Many of them, in fact, all of them, are still on the governor's desk for signature, and her team still does need time to review the bills. A number of them, a lot of them, I should say, just made it formally onto her desk yesterday so her team could start the process. We also heard from her team that the governor will not be planning on vetoing any bills before the 25th or before Christmas. She just doesn't feel like that would be right. So we do expect a lot of activity to happen around these bills after the 25th and not a lot to happen before. So, as I mentioned, the state did pass a budget supplemental of around $465 million. It was presented to the governor formally yesterday around 4 p.m. The biggest chunk of money in this is $262 million being used to cover the temporary unemployment extension. But for long-term care, there's a couple of important things. There is about $104 million to help support vaccination testing and COVID-19 response efforts. The $2 an hour direct care worker wage increase has been extended for an additional 2 months with $100 million in funds. And then there was also $2 million to extend the $200 per day enhanced payment for CRCs for an additional 2 months. So these have been extended until the end of February in this bill. It has not yet been signed by the governor. She just saw it yesterday, but this was negotiated between the legislature and the governor has spoken positively about it. So we do expect her to sign this as kind of the final, this will be the final draft, so to say, of the legislation, or the final. So I had mentioned a couple of bills previously in the webinar, just a quick update on where they sit. Senate Bill 77, which is that electronic monitoring bill for SNFs, is on the governor's desk still. We have had conversations with the governor's policy team, and they indicated that right now the governor's not a fan of the bill, but they didn't say either way whether she will sign it or will not sign the bill. They did mention a couple of interested parties that may be standing in the way of the governor signing the bill, outside of ones we knew. So that is where that bill stands. The medication aid bill, the governor's team did not comment on that bill, but we do know that bill was passed along party lines. So we'll see what happens, but usually when a bill in our state right now is passed along party lines, it's not a good sign for the bill getting signed into law. That's largely because our parties aren't necessarily on the best of terms right now. The healthcare facility legal immunity bill is also on the governor's desk, awaiting signature. It is important to note that the governor hasn't commented on it, but it took a lot to pass the last immunity bill for healthcare facilities. It was done through a negotiation process with another supplemental budget. So we do not expect this to get signed, but you never know. It was also passed along party lines. So the signs aren't lining up positively, but you never know what happens behind closed doors sometimes, especially nowadays as people's opinions change on the hour. Some other bills, just to note, I have mentioned them on previous calls, but that was a while ago. House Bill 4910 and 4911 is titled the Misrepresentation of Emotional Support Animals Act. What this bill does is it creates more flexibilities for housing providers or landlords to seek more information regarding kind of the validation of a support animal. This passed with bipartisan support, but it was kind of a mixed bag. So it was still a majority, but it wasn't everyone from every party. The next bill is Senate Bill 1021. This would create license reciprocity for those individuals educated in Canada. Currently, Michigan doesn't recognize any degrees or education that took place in Canada to count towards licensure in the state. This bill would change that, and this was passed by the full chamber with only one dissenting vote throughout the entire process. So we do expect this to get signed. House Bill 4042 would add Michigan to the list of approved states for the National Nurse Licensure Compact. This would mean a Michigan nursing license would be applicable in many other states, and many other nursing license attained from other states would be applicable in Michigan. This passed with a mixed support, but it was bipartisan, just wasn't everyone voting for it. And the last bill is House Bill 4491, and this would change the licensure requirements relating to good moral character. This would make it so only felonies can be reviewed upon the licensure application of an individual, with some exceptions dependent upon the license type. And this was passed with that same kind of mixed support as before, but did have votes from both parties. So I updated the important date slide since the direct care worker wage pass-through was extended, and the $200 enhanced CRC payments have been extended till the end of February. Please note the next deadline is the 31st, and this is the deadline for the purchase or initialization of equipment paid for by the Nursing Facility Infection Prevention Grant Program.
All right. Thank you very much, Dalton. Before we before we get into any questions, I did just want to mention that we just sent out a flyer this morning and we have opened our registration for a two-part live virtual training for our Finance and Strategy Day. It will be held on January 7th and January 21st. And on the 7th, we will be hosting our friends from Plant Moran, MISTA, HUD, and Therapy Management. So that's packed with a lot of good information. And then on the 21st, we will open the two-day portion of our finance and strategy event with our friends from Ziegler and panel discussions by leading age members Jeff Hughley, Jay Prince, and David Tiesnug. Sorry about that. So we do have a lot of great information, a lot of great content going on during these 2 days. Like I said, it will be January 7th and 21st. We do have registration open, so you should have received a flyer this morning. If not, you can go ahead and head over to the leadingagemi.org website and just click on that events tab, and it will be the very first event that pops up, and you can go ahead and register there. Looks like we have one question. Historically, labor and the trial attorney lobby opposed medication text and video monitoring. Is it your sense that these groups are still opposed?
Yes, in fact, those were the two groups I didn't want to mention by name, but that is the two groups who are kind of lobbying the governor very hard. Trial attorneys and labor organizations have supported the governor for a very long time. And so they're very close to her heart. So those are the two groups who are opposing that kind of legislation, and the historical trend does follow that as well. So that's kind of the two groups standing in the way of those two bills.
Okay, thank you for that. It looks like that was our last question, so we can go ahead and move forward.
All right. Thank you for having me here today. My name is Elisa Lintemuth, and I am a labor and employment attorney at Dykema. And I am here to talk about a pretty hot topic right now, COVID-19 vaccines in the workplace. So historically, vaccine programs that mandated employees to receive vaccines like flu vaccines have been upheld by courts and by guidance from various authorities like the EEOC and OSHA, and have confirmed that employers can require employees to be vaccinated if the requirement is job related and consistent with business necessity, which most healthcare employers can meet. And if employers allow accommodations for employees who have medical and religious exemptions under the Americans with Disabilities Act or Title VII of the Civil Rights Act. Next slide. So employees who have a qualifying disability that prevents them from receiving the vaccine might be entitled to an exemption from a mandatory vaccine and policy. And historically, those sorts of disabilities have included allergies and a history of Guillain-Barré syndrome. The current COVID-19 vaccines, the Pfizer and Moderna vaccines, include only two contraindications. The first is for known allergies to any vaccine ingredient, and the second is if the individual has had an allergic reaction to the first dose of the vaccine. And there are reports from the United Kingdom and Alaska and a few other places of anaphylactic reactions to the Pfizer vaccine in the first couple weeks of administration. So employers may want to err in favor of granting accommodations to employees based on allergy-related disabilities. But historically speaking, minor sensitivities and undocumented allergies are not sufficient to constitute a disability under the Americans with Disabilities Act. So if an employee says, oh, I'm allergic to some ingredient of the vaccine, but they don't have any evidence to support that beyond their own statement, you may be able to deny an accommodation, you are allowed to ask for, additional information from a physician or healthcare provider that would support a claim of a disability. The EEOC has generally advised employers that they should accommodate pregnant employees' requests not to be vaccinated. And here that kind of accommodation makes sense because the Pfizer and Moderna vaccines were not tested on pregnant women in particular. So there's a good basis for an accommodation there. The other basis for objection to a vaccine under the law would be for sincerely held religious beliefs. And for a belief to be sincerely held, it doesn't need to be a mainstream belief of any particular organized religion. In one case out of the Southern District of Ohio, the court actually held that veganism could be considered the basis for a religious objection, where the employee characterized her beliefs as moral beliefs as to right and wrong and cited to passages from the Bible to support her vegan views. Notably, though, political or intellectual oppositions to vaccines, what have colloquially become known as anti-vaxxer views, don't entitle an individual to a religious exception. And courts from a number of different jurisdictions have held that that's the case. So there has to be a belief as to moral issues or what's ultimately right or wrong, end of life, things like that, that to qualify as a religious objection. And personal beliefs that are not rooted in the same sort of moral teachings are not entitled to protection under Title VII. I will say that the only real mainstream objections I've heard to the COVID-19 vaccines, there were a few Catholic bishops that questioned the morality of the vaccine given the link to cell that were derived from abortions. But since then, the Vatican has clarified that it views vaccinations as moral. So I'm not sure how many people you'll have with beliefs like that, but that's the only more mainstream belief that I've seen that could form the basis of an objection to the COVID-19 vaccine beyond something like Christian Science, which would object to any vaccine. So if you have an employee who makes a request for an accommodation to a vaccine policy, you need to engage in the interactive process. That is the process that you typically use for employees who have a disability. And an employer can deny an accommodation if it can prove that it would constitute an undue hardship. And the standard for undue hardship is different under the two laws. So if it's a religious belief, it just needs to be a de minimis burden or cost. If it's a disability under the ADA, it has to be a significant difficulty or expense. So the undue hardship standard is harder to meet for disabilities than for religious beliefs. And any accommodation that would pose a direct safety threat to employees would amount to an undue hardship. So you could deny the request for an accommodation to a vaccine policy if it would put your employees or residents at risk, and there's no other way to prevent that risk. But there are other accommodations that you could require them to not work in a direct patient care position, to work remotely if that's feasible for their position, to wear additional PPE or socially distance from other employees, attend meetings remotely, things like that. So this is an individualized, you have to look at each employee's circumstances and make the decision based on all of the various tasks they perform as part of their work, the specific disability or religious objection they have, and decide the best way to deal with it. So fortunately for us, the EEOC just issued updated guidance related to the COVID-19 vaccines and confirmed that an employer can require the administration of any vaccine that's been approved or authorized by the FDA, as long as it provides the exemptions that we just discussed. And I found that approved or authorized language particularly relevant, because although the EEOC didn't come right out and say that an employer could require employees to be vaccinated with a COVID-19 vaccine that was approved on an EUA basis, and although it's not approved under the licensure process, the COVID-19 vaccines have been authorized by the FDA. So that's a bit of a green light for employers. Courts don't have to follow the EEOC's guidance, but it is very relevant and courts give it a lot of weight typically. So, that's certainly helpful guidance. The other thing the EEOC said in its recent guidance is that vaccination on its own is not a medical examination under the Americans with Disabilities Act, which avoids some areas of liability for employers. But if an employer administers the vaccine itself or hires a third party to do so, and there are pre-vaccination screening questions that are asked, those questions could be considered disability-related inquiries, which have to meet the ADA standard of being job-related and consistent with business necessity. The EEOC said that to avoid these issues, employers could decide to either offer vaccination only on a voluntary basis, in which case employees would be providing that information voluntarily, and so a different standard would apply, or employers could simply require employees to show proof of vaccination from a third party that does not have a contract with the employer. So, a pharmacy, CVS, Walgreens, etc., health department, healthcare provider, instead of providing vaccines on site or contracting with a vendor to provide them on site. The EEOC also provided some guidance on accommodations for employees who have requests for accommodations, and has confirmed that employers should conduct an individualized assessment and determine whether an unvaccinated worker actually constitutes a direct threat to the workplace. And in making that determination, employers should consider the number of employees who already have received the COVID-19 vaccination, the amount of contact the employee in question has with others whose vaccination status could be unknown, and other factors like that. So it's not a black and white answer. Each case you'll have to look at individually. And if you cannot provide a reasonable accommodation to the vaccine accommodation request, the EEOC said it would be lawful to exclude the employee from the workplace, but that it doesn't mean you can automatically terminate your employee, and you'll need to determine whether they have any other rights under various laws to continue to be employed. So it might be that they could go on an unpaid leave of absence for some period of time if you expect that herd immunity might be reached soon in your facility, or maybe moving them to a different position where they could work remotely or have less contact with others might be another option. All right, so, historically, as I mentioned, courts have upheld mandatory vaccine policies. So the question is COVID-19 any different? And I think it is for two reasons. The first is that COVID-19 is more deadly than any other communicable disease that modern workforces have faced. And the EEOC has confirmed that COVID-19 meets the ADA's direct threat standard, which allows employers to take actions they normally wouldn't be able to take, like taking employee temperatures, screening employees for symptoms, requiring employees to be tested for COVID. And because of this, I think there's really good business reasons that an employer would require employees to be vaccinated for COVID-19. On the other hand, COVID-19 vaccines are different because the first vaccines available have only received emergency use authorization from the FDA instead of the full BLA license. So it's possible that a court could find that mandatory vaccination rules are different for COVID-19 than, say, your typical flu vaccine. So I'm sure you all know a fair amount about emergency use authorization by this point. It's a rigorous process, but of course it's not supported by the same long-term safety data as we're used to with other vaccines. And the point where I think a court could step in and question mandatory vaccine policies is that the EUA statute specifically states that individuals to whom the product is administered are to be informed of the option to accept or refuse administration of the product, the consequences of refusing, and the alternatives to the products that are available and their benefits and risks. And I could see the right judge getting a case and saying, well, is it truly an option to accept or refuse administration if the consequence is termination of employment? I think the right answer is yes, that's still a choice, but I do think there's a judge, if the right judge got the case, he or she could disagree. So what are some practical concerns as you decide whether you want to mandate or encourage vaccination? And I think, one of the primary concerns is that employees may react poorly to a mandatory vaccine program. A recent Gallup poll showed that only 63% of Americans would agree to be vaccinated. And that percentage is actually up from September when it was only 50%. I anticipate that the number will continue to increase as the general public becomes more comfortable with the vaccines, as more individuals they know receive it. But currently there's certainly a large portion of the general public that would not agree to receive a vaccine. And so if you implement a mandatory vaccine policy, you may lose employees. And I know in Michigan, at least, all the large hospital systems have reported that currently they are only encouraging vaccination, not mandating it. And I know that there are nursing shortages everywhere, so they would be more than happy to take any of your employees who don't want to be vaccinated. Some other practical concerns. The first is a legal one. If you have a mandatory vaccine policy, you need to consistently enforce it so that similarly situated employees are treated similarly. That will help you avoid a discrimination claim. So before you implement a mandatory vaccine program, you should determine in advance how you will react if a number of key employees refuse vaccination and do not have an exemption under the ADA or Title VII, and if your company is really willing to terminate employees who refuse to comply with a mandatory vaccine policy for personal reasons. The next is more of a logistical concern. As I'm sure all of you have heard, there are reports of flu-like symptoms after the second vaccine in both the Moderna and Pfizer vaccines. And so in order to continue to operate, you need to stagger the vaccination of key employees and employees who work within the same department or job description. And if you do stagger employees, do you have any concerns that employees will refuse the second injection once they hear from an employee who does have a more dramatic response to the second vaccine? So some more practical concerns. I mentioned the concern that you might lose employees, which might weigh in favor of encouraging rather than mandating vaccination. On the other hand, as you all know, the threat of COVID-19 is much higher in senior care facilities, and if COVID-19 spreads in your facilities, the mortality rate will be much higher than it would be in other medical facilities and in the general population with other employers. We also expect that there is going to be a push from families to place their loved ones in facilities with vaccinated workforces. And so from a marketing standpoint, that may be something you find beneficial for your business, and that would be a business reason for vaccination under the ADA standard. So if your clientele, really is demanding vaccination because they feel that they need that for their safety, that may be one factor to weigh in favor of mandatory vaccination. And as I mentioned, on the other hand, staffing shortages could increase if you mandate vaccination. Whether or not you mandate or encourage vaccination, you can be a source of science-based information to your employees. There is a lot of fake news out there on social media that some of your employees may be reading, and if they are fully educated on the vaccines, their benefits and risks, that may help them to make a more informed decision. And simply seeing leadership stepping forward and volunteering to receive a vaccine may increase their comfort with the vaccine. Another practical concern is whether you would provide employees with paid time off to go get the vaccine if you are not providing it on site, and whether you'll require employees to use their sick time if they do have an adverse reaction or experience symptoms following one of the vaccines. If you're a unionized employer, you may need to review your collective bargaining agreement to determine whether vaccine programs are a permissive or mandatory subject of bargaining. And whether or not you're a unionized employer, you should be on the lookout for employees who are engaging in protected concerted activity. Employees who speak out for a group and not just on their own behalf about concerns that they have about safety in the workplace are protected under the National Labor Relations Act. So, think twice before you discipline an employee who is speaking up on behalf of a group of employees about concerns related to vaccination. So there's a lot of information here, and I don't think there's one right answer for every employer. What's right for you depends on your workforce, your facilities, and the impact of COVID-19 on your business. Also, your plan doesn't need to be set in stone. It can change. Right now, you could say we're going to encourage vaccination and maybe even provide a small incentive to employees who are vaccinated. And later on, once the FDA provides full BLA approval for the vaccine, or once the public comfort level with the vaccine increases, we're going to start mandating it. And ultimately, one thing you need to do is to keep up to date, because rules and guidance may change as we learn more about COVID-19, as we learn more about these vaccines. OSHA has not updated its guidance yet on COVID-19 vaccines, and currently I haven't seen any state or local orders that really deal with COVID-19 vaccines in the workplace. For example, none of the mask orders provide any sort of exception for those who've been vaccinated, and we don't expect that to change anytime soon, just because it's going to take a while for employees who are vaccinated to have immunity, and we're not sure whether they could still carry the virus and what the herd immunity threshold is, or how long it will take us to get there. But keep your eyes open for changes to relevant rules and guidance so that you can stay in compliance.
All right, thank you very much for all of that, Eliza. We do have a couple questions, so I will just jump right into those. Given that the EEOC opinion was just 12/16/20, how long do you think it might be before the FDA transitioned the vaccine from the EUA list?
Well, I don't know that the EEOC guidance will necessarily have any impact on how quickly the FDA moves to BLA approval. That, as I understand, depends on some additional information from further stages of the vaccine trials, and information that the FDA should be receiving as individuals are vaccinated with these EUA vaccines. I'm not sure how long it's going to take, but I know the FDA is working to remove as much red tape as possible that slows down the normal vaccination approval process.
Okay, thank you. Since our facilities are required to have COVID units with dedicated staff, can we mandate those employees without the rest of the entire staff?
Yeah, that's absolutely one option. And so you could say that employees who are unwilling to be vaccinated can't work in the COVID units, and wouldn't be eligible for additional COVID unit pay, things like that. I think that's a good distinction to make, in a way to draw a line in a logical, non-discriminatory manner.
All right, thank you very much. It looks like that was the last question. So if anybody does think of a question, maybe after the webinar has concluded, you can see that Eliza has her email and phone number to contact her right now. And we would just like to thank you again, and we would like to thank the whole Dykema team for standing along both Leading Age Michigan and our members during this challenging time and during this pandemic. So with that, we will now, yes, no problem at all. And so now we will turn it over to Dana Prince of St. Anne's. So thank you.
Good morning. Thank you for having me. I'd just like to give you all an overview and some lessons learned of our COVID Care Recovery Center at St. Anne's. It's been quite a journey for us, and we're pretty excited to share some of the ups and downs that we've experienced. So a little background on St. Anne's. We're a not-for-profit Catholic organization offering assisted living, skilled nursing, and memory care. We did see an opportunity at the beginning of the year when this pandemic hit us, and we have a designated memory care long-term care unit with 10 private rooms. So we decided to convert that into an internal COVID care unit, or what we called a CCU at the time. How we felt that this aligned with our mission, we felt that it fulfilled the mission of the Carmelite Sisters, and with board support, just because of the fact that we're providing services which reach older adults that were in need in our community, as well as now throughout the state of Michigan. So that really did align with what our mission stated. Some of the timing overview, we opened in April with our COVID care unit, dedicated staff caring for internal COVID positive residents just within our community until about August, when everything sort of calmed down. And then fast forward to now, we've reopened as a CRC in November, knowing that there was an uptick and we were starting to see a couple of positive cases within our own community for internal residents. But then what was new to us is starting to take external transfers, so folks from the outside. Here's a little floor plan just to give you an idea of what our site looks like. It is ground level. It is a wing. It's a unit off of a clinical hallway from our skilled nursing. It is separated by a fire door, which allows for physical isolation from all the healthy residents, the general population of residents. You'll see we have 2 exterior doors, one for entry and one for exit. So staff have to come through one area and exit the other. Same thing if any supplies come through those doors, they come in one way, they exit another. And same thing for patients as they enter and exit the facility as well. We do have one interior door that's used to deliver meals and supplies that's connected to the general population through that fire door, but no staff are permitted to enter or exit that space. It's just for sheer supplies. We do have a dedicated staff restroom, a kitchenette, storage units, and workspaces within this particular CRC. So those are some unique advantages that we saw to this unit upon opening. When we determined our dedicated staffing way in the beginning, in March when we were putting this together, we identified kind of our key staff members who really were gung-ho and excited to take this on full-fledged, full storm. And a lot of it was volunteer basis. There wasn't too much from a recruiting standpoint. We had people that were excited to get involved and get their hands dirty, I guess you could say. After conversion to our CRC here in November, we were starting to receive the monthly MDHHS stipend, which did allow us for a pretty generous wage increase in order to incentivize an enhanced dedicated team. So we essentially were able to keep the same team back in the beginning of the year with a couple little changes here as turnover happens organically. But our dedicated team did stay together and we were able to give them a nice boost of pay with that MDHHS fund. Our day-to-day looks like 12-hour shifts on this particular unit. So on days and on nights, we have 1 nurse, 1 CNA, 1 medical support tech that helps with cleaning and meals and stocking, things of that nature. And they also are CNAs, so they do help us with the CNA work whenever the case gets a little heavy. And then we have 1 RN case manager on the days to help out with any of the referrals and communications back and forth to families and hospitals and so forth. Other support staff that we have, such as social work, life enrichment, any of the contracted physicians and contracted therapy workers, we do quote unquote share staff. So the staff members do work in the general population. Those individuals work with the general population during the day. and then they will transition into our CRC to end out their day in the event that they do need to provide support to those patients and staff back there. So then they go home, they clean up, and then they come back and they start it all over again, working in the general population if they have to end up going back into the CRC. And this was approved through several of our infection control or COVID surveys as well. They felt that this was a good process. We have run into some contingency situations with staff who do test positive. We've actually had 2 staff that tested positive for COVID here recently, and we did have to enact for the first time, the emergency staffing plan. We've been very fortunate that we haven't had to run into that. But we started it off by identifying that the person was asymptomatic, the staff members were asymptomatic, and we asked them if they felt comfortable to work to take care of those COVID patients, and they did. And they were just more worried about the rest of their coworker team to ensure that the CRC team was comfortable with them working with them. So we had some nice conversations with the staff back there, and they felt very comfortable having them come in, and with appropriate PPE and appropriate processes, we've been able to continue keeping our staff up when that does occur. Next. Now some of the economics in billing. I know that's quite interesting and probably of interest to many of the members that are considering this particular CRC model. We are a tier 3 CRC, so that means we're within the 10 to 24 bed designation. Our origination stipend was $40,000. We did receive this within 2 weeks of application acceptance. It does come as a standalone payment through an electronic funds transfer, sort of the way that Medicaid pays their claims. So you must have a Sigma account. We were informed recently that there is now a regional incentive add-on for regions and certain counties that fall into these high-risk areas. We are Region 6, sitting at a Tier 3, so we should be expecting a $60,000 incentive stipend through that electronic funds transfer as well. In addition, we receive a monthly stipend of $10,000. We, as an organization, have decided to use this $10,000 a month for that staff base wage increase for the CRC staff. So we don't necessarily use this for any other operations except for the payroll for that team. And then we receive a per bed stipend. So it's $200 per occupied bed. It is an add-on to their insurance premium. So we're provided a document through MDHHS, and we have to track the census. We keep it up to date, and it is based off of their 10-day isolation. We then upload this monthly through a file transfer, so it is HIPAA protected. Some of the interesting nuances with this is that it is based on 10 days. So if somebody goes into the hospital, they're at the hospital for 4 days, then we would only have technically 6 days of continuance of their isolation with us in the CRC. Now, that doesn't mean that we push them out on the 6th day. If insurance asks them to stay, working with their case managers, usually with Navi Health, they might stay a day or two after that 10-day isolation, which is okay. They're safe, they're ready, we're planning their discharge. We just can't bill for that $200 in excess of that 10-day isolation. Some other inconsistencies that we ran into is with how counties define what day 1 is for COVID positive tests. So that impacts us from billing or asking for that $200 to MDHHS. So examples being, we're in Kent County. So day 1 is the first day for day 1 for us in Kent County is the day that they first test positive for COVID. In Shiawassee County, their day 1 is the onset of symptoms. In Ingham County, we're now learning that their day 1 is the day after a COVID positive test. But we've been able to consult with Laura and get some answers, and they're defining day 1 as the day that they test positive for COVID. So we've been going by that methodology. So again, once the 10-day is complete or ended, we still receive payment from the insurance company for their per diem rate. We just wouldn't be billing for that extra $200 from a day from MDHHS for those individuals. Next slide. We did receive some grant support through MDHHS. As soon as we applied and were accepted for the CRC, we were given the opportunity to apply for the infection control grant. And this is probably the fastest grant I've ever applied and was accepted for. The turnaround was like within a day or two, perhaps. And we were given just over $16,000 to help us with the supports in the CRC. So with those particular funds, we purchased a bipolar deionizer for our HVAC system. We upgraded our air handler filters from a MERV 8 to a MERV 13. We did some touchless bathroom enhancements. We also purchased a couple thermal scanner health screening equipment. So a little photo here to the left, you've probably seen it if you've been to different locations. They place their face within the screen. It determines if they have a fever, and it also asks them all the questionnaire, and it has facial recognition. So a lot of this truly is touchless, and we can get away from the technology that we're using on our phones of doing the health screening. Makes things a lot faster. We also purchased tablets for each private room with wheeled mounts so that they can enhance their time with their family members on Skype calls and things of that nature. And then telehealth can be utilized per whenever the patient has the time to meet with them as they're scheduled. And we purchased a UV cabinet for PPE sanitation as well. Next. Now, diving more into PPE, we do monitor with a burn rate calculator that is unique to this unit. So it is tracked separately from other units and levels of care at St. Anne's, which is something that we have to do as a CRC. But what they do is they provide extra support to us. So MDHHS will provide PPE required to support the number of CRC staff that you have on that unit. So you fill out a sheet, you turn it in before whatever set Friday. As long as they have it in their hands, then they ship it out. And it takes within a week maybe to even get the PPE delivered to us. And you do it as you start running low. So the drop shipments that we've received have been about 2 to 3 weeks worth of PPE. It's pretty generous. So that was something we weren't anticipating, and pretty exciting. Next. Talking a little bit more about community partnerships with our CRC. When we first opened up as a COVID care unit back when we were preparing in March, we partnered with Spectrum Health's Infectious Disease Department to build and beef up our infection prevention program. So we had an infectious disease representative come out and do PPE education for us, and also reviewed all of our program to make sure that we had everything in place, that we were cleaning and reusing PPE, which was a completely different world to all of us. So that was something that we were making sure that we were aligning with what the hospital practices were. And we also kept those communications close throughout this year so that we're all on the same page and performing the same programs. Now, as we opened up as a CRC, we were anticipating referrals to come our way. So we incorporated a similar partnership model into our CRC referrals. So we set up initial meetings with Mercy Health St. Mary's and Spectrum Health discharge planners just to align kind of, okay, what are you seeing? What do you think you're going to refer? These are the age requirements that we're looking at. What ages are you seeing that you would need to refer? And then talking about what our abilities medically that we would be able to do to take care of these folks too. We create an internal single point of contact. That's our case manager, a single cell phone, and an email for those referrals only. But what we're finding actually is more senior care organizations throughout the state of Michigan are needing our help. So actually 90% of our admissions have resulted from these referrals, not necessarily from the hospital. And this has been a really great transition for us. And I think it's a really great help out to industry leaders too. It's been a good experience for us. Next. Diving into the insurance and pairs, through our intake system, we've created a multidisciplinary admission review, sort of a smaller intake group that you normally would have for your typical rehab admissions. So we have our case manager, finance, social services, and therapy that get together, review the case, ensure that they can get them in as soon as possible. We are requiring that prior authorizations from hospital discharge planners for select managed care plans are done before they admit. The facility to facility transfers, we're asking that they do those prior authorization requests beforehand for ease of admission as well. And then And a lot of it, or we're finding some bumps in the road. Some payers have not covered COVID recovery charges in our area here specific to Grand Rapids. So that's why it's making it a little bit more stringent, making sure that we have the prior auths in hand, that we feel good with the insurance company before they move in. And we've been able to streamline this process so that it's within hours that we're able to have this determined before they admit to us. Just important to note is pay source is not a condition of admission. So we do and would admit Medicaid only patients as medically appropriate for the CRC. Next. Case management has been really exciting of a experience for our team too. It's very high, very fast turnover, very fast pace. Our length of stay is well below 10 days. When we're looking at admissions, we're reviewing those that actually have a discharge plan. They can't stay with us. We don't have long-term beds for them. They would have to have somewhere to go home. Within those discharges, we're finding that many actually need long-term care. So we communicate very clearly with the family in order to reduce any potential to find alternate placement. So that starts with the discharge planners at the hospital and the facility to facility transfers, getting to know those patients at a different level so that we know you have a place to go home to after this transition. We have had a few cases where folks have needed additional rehab care after their 10-day isolation. When they come to us, they're rather deconditioned, so they do benefit from PT and OT. So we have found success at admitting and transferring after the 10-day isolation in our CRC into our own general population rehab space. We're finding that many of the patients really do need a lot of rehab. So we've been able to make those accommodations, or we send them home with their home care or the facility and they can take care of them from a rehab standpoint. So that's been a really interesting case management experience for us as well. Next. And further into case management, bed management. You've probably heard, if you've been looking for CRCs to take maybe some of your own COVID positive patients, we do try to keep 1 to 2 dedicated beds available. We sort of juggle that as much as we can, just for internal bed availability for St. Anne's potential COVID cases that could present themselves. We balance this based off of the infection rates in the county and outbreaks perhaps in-house. And an outbreak, of course, is just one person. So we keep a close monitor of pending discharge dates of CRC patients as well. Insurance updates actually post for longer lengths of stay sometimes as appropriate and determined by the insurance case manager. Typically it's through Navi Health, who we're working with in this area. So again, we don't bill for that $200 if it's over the 10 isolated days, but sometimes they need to stay with us and have a little bit of a buffer in our unit. So we're monitoring those pretty closely so that we're juggling when we have an open bed. And St. Anne's residents at this point in time, because of the infection rates in Kent County, they're tested weekly for COVID. So that kind of gives us a little bit of something to cling on to too. Okay, on this day, we're going to do our COVID test. Potentially, if we get a positive case, do we have a bed available in our COVID unit in the CRC? So we weigh a lot of those juggling options. So thank you so much for your time and listening to our experience. I'd be happy to answer any questions that you may have.
All right, thank you very much, Dana. It looks like I just have one question right now. How is St. Anne's handling the topic of staff vaccinations?
Sure. And Elisa, thank you so much for your presentation too. I think that was pretty helpful. We are not mandating vaccinations. And something that was kind of interesting hearing about the case of potentially mandating folks that are working in the CRC. We're not mandating CRC workers to be vaccinated either. There's actually a couple staff members that don't even want to be vaccinated back there, and that's fine. I mean, we're still giving them the PPE in order to do their job. But there are some implications with if we did mandate having enough even vaccines that would be coming through our building and for new staff that would be working with us. So we haven't found that logistically would work, knowing that we don't know what additional vaccines may be coming through our doors if we have new staff that would be starting with us.
Oh, okay. Can you tell me the acuity level of the admissions that are coming in?
It's determinant on, we really have upwards of 20 referrals that we can see and look at and choose from in a day. So it's determinant on what you feel that you can take. We're seeing a lot of referrals coming in that are young, in the 40-year-old population. So we've actually talked about whether or not we want to take those at this point in time. Right now, we're just taking over 65 because we can, and it's filling up our beds. And we've only had a handful maybe that are dialysis or tube feed. Really, they're just coming to us extremely deconditioned from a rehab standpoint. These guys are just very tired, not high acuity or high medical complexity. We've had maybe 10% of our admissions come through that are behavioral, but nothing that isn't manageable for our team. So I guess, long story short, the acuity isn't very high. It's just they need a lot of time and attention because of how deconditioned they are.
Okay. Do you know if you must be a Medicaid provider to become a CRC?
I don't know if you have to be a Medicaid provider, but you would have to get the Sigma set up in order to be paid. So you would have to get a Sigma account.
Oh, okay. Can members considering becoming a CRC contact you directly for more information?
Yes, I'd be happy to answer any questions. Feel free to give me a call.
All right, sounds good. It looks like that was the last question. So we want to thank you again, Dana, and now I will turn it back over to Dalton Herbal.
Thank you, Blake. Thank you, Dana, and thank you, Elisa. We appreciate your presentations. I think today's presentations are really a great example of the shared best practices that we can share across membership. And so if you have any other topics you'd like to learn about or have any ideas you'd like to share, please feel free to contact us and submit those topics, and we'll see what we can do to address those on these calls. Thank you again to both Dana and Elisa, and happy holidays to everyone who has a holiday coming up. And I hope everyone whose holiday has passed had a good time and a happy holiday. Thank you, everyone. And please take care, and remember that our next webinar will be tentatively scheduled for December 30th.
All right. Thank you, and everyone have a great holiday.
Take care.